Hello, everyone. My name is Martin Hoenigl. I am the current president of the European Confederation of Medical Mycology and an associate professor for infectious diseases and specifically translational mycology at the Medical University of Graz, Austria. As the president of the ECMM, it's really my pleasure to welcome you to this ECMM Healthbook CME live webinar series. So a total of 4 webinars are planned as part of this series, and on behalf of ECMM and Healthbook, it's my pleasure to announce the first webinar, which is on antifungal resistance in molds, the impact on the selection of antifungal therapy. Next slide, please. So together with my co-chair, Professor Verweij, we will guide you and share you through this session. Next slide, please. So the speakers, and I'm very proud of the speaker panel today. It's a good mixture of, upcoming hot scientists like Eelco Meijer and to some extent still Agostinho Carvalho. And then, of course, also Professor Bart Rijnders. So Eelco Meijer will start off bringing us a case report and really outlining lots of the problems we are facing during antifungal resistance in molds, followed by Agostinho Carvalho, who will really focus on translational mycology, immunology, and resistance mechanisms here specifically, and talk about these resistance mechanisms in molds, followed by Bart Rijnders, who will talk about resistance to therapy in daily clinical practice. And specifically also will focus on what are our therapeutic options and management strategies. This will be followed by conclusions by Paul, Verweij, and myself. Next slide, please. As said before, this webinar series and this webinar are provided by the ECMM in collaboration with Healthbook and are supported by Gilead Sciences and further co-sponsors. Next slide, please. Here, just a disclaimer. I'll leave this on for a few seconds. Next slide, please. And with that, basically, I just wanted to invite you to always ask questions. You can always ask questions during the live webinar, and we will discuss these questions and forward these questions to the speakers just after their individual talks. And with that, I would like to hand over to my co-chair, Paul Verweij, who will introduce the first speaker.
Thank you, Martin. I hope that everybody can hear me.
Yes, we hear you very fine, Paul. Hi.
Good.
Thank you.
So, hi, everybody. My name is Paul Verweij, and I work as a professor of clinical mycology in Nijmegen in the Radboud University Medical Center. And it's my great pleasure to introduce Eelco Meijer, who is a resident in clinical microbiology at the Radboud University Medical Center, who works with us together in our center of expertise, which we have in collaboration with the Canisius-Wilhelmina Hospital. So Eelco has a keen interest in medical mycology, and as already indicated, I think he will pursue a career in clinical microbiology with special attention to clinical mycology. So Eelco will start off this webinar and talk about a clinical case in which resistance played an important role. So Eelco, the floor is yours.
I hope this is visible. Is this okay? Thank you for the kind introduction, Paul. I'd like to thank the host for inviting me as well. So I'll be talking about resistance to therapy in daily clinical practice. As Paul said, my name is Eelco Meijer, and I'm MD PhD in clinical microbiology. So the content of my presentation, I'll start off with some background before I go to a COVID-associated pulmonary aspergillosis case report, and continue to talk about clinical management, limitations of amphotericin B, touch a bit on the immune system combative fungi, but won't go into much detail because of the second speaker. Then isoflurconazole, posaconazole, echinocandin, and novel drug alternatives in the case of resistance, and conclude with some slides on agricultural use of antifungals. So first, some background. And talking about Aspergillus species, then Aspergillus fumigatus is the species most frequently encountered worldwide. In subtropical climates, Aspergillus flavus is also more common, and Aspergillus tertius is common in specific locations, but infrequent elsewhere. This is, of course, very relevant because of the intrinsic elevated MICs for amphotericin B in this species. It's important to know that local resistance epidemiology dominates the choice of primary treatment, and there is about 25 to 30% increased mortality when invasive disease is caused by an azole-resistant strain. So here I have a map. It's an old map from 2019. You can see the Netherlands. I hope you can see my pointer. Netherlands right in the middle, the little red country. There's a high resistance percentage in the Aspergillus fumigatus of above 10%. And this really differs throughout the world per country. Not all countries have listed their resistance percentage of no their resistance percentage, but resistance is really global and it's everywhere. When talking azole resistance, can make the distinction between the CYP51A mediated resistance mechanisms and also the non-CYP51A mediated resistance mechanisms, or also make the distinction between an environmental source versus a long-term azole use, for example, in chronic pulmonary aspergillosis or cystic fibrosis, lung cavities, or other lung abnormalities or lung disease. Important to note, though, that non-CYP51A mediated resistance mechanism seems to be increasing, also environmentally. But for now, when you have an environmental source, the most common resistance mechanism is the tandem repeat 34 combination with the L98H mutation, which is often associated with itraconazole and posaconazole resistance, and the variable voriconazole and isobuclazole susceptibility. Another one that's well known is the tandem repeat 46 in combination with Y121F, which actually has is often voriconazole and isobuclazole resistance. Specifically for Kappa diapa, which is COVID-associated pulmonary aspergillosis and influenza-associated pulmonary aspergillosis, you often see these disease entities in at least before the immunocompetent patients with no azole treatment history. So you would expect environmental resistance mechanisms in these patients. So this as an introduction to the case. Case is I published in 2020. This was back in the days when we still used hydroxychloroquine as treatment and no corticosteroids. This is a busy slide, but I'll guide you through it. It was a case of a 74-year-old immunocompetent patient who had typical presentation of COVID with fever, dry cough, was dyspneic. 2 weeks later, was admitted to the ICU with respiratory insufficiency, and a BAL, a BAL was performed where Aspergillus fumigatus was cultured and a really high galactomannan was found in BAL fluid. Then empirical therapy was started with voriconazole caspofungin, which is echinocandin, and we use double therapy because of our over 10% resistance we find in the Netherlands. So that's common practice. So we started voriconazole caspofungin, but about a week later, the patient deteriorated. Another BAL was performed to exclude perhaps to look for resistance mechanisms or to look for an alternative diagnosis. What we found was again Aspergillus fumigatus, but this time with azole resistance with a tandem repeat 34 L98H mutation. Patient was switched to amphotericin B, which is what you commonly do, and soon after, patient died with multi-organ failure also, but renal failure before then. Few things I wanted to point out. There's the environmental resistance mechanism that we found in this patient, which would be expected with a previously healthy patient. MICs were high for itraconazole, elevated for voriconazole, and elevated for posaconazole. And again, the amphotericin B, we'll talk a bit more about that drug in the next slides. So in clinical management, most invasive aspergillosis patients, they encounter amphotericin B drug toxicity after days to weeks. while treatment usually lasts for months. So this is a problem. And there's always the importance of the immune system in combating fungi. So always keep in mind when treating patients that if they have immune disturbances that you know of, you should always try to get their immune system as optimal as you can. There's a nice paper from Professor Agostinho Carvalho, sorry for the pronunciation, but I won't go into too much detail, but he discusses kappa and yappa on and the relevance of the immune system, and also discusses interferon gamma. So this is a really nice read. But just keep in mind the importance of immunosuppressed, or at least the immune system in patients, and try to get them a bit less immunosuppressed. So when talking about proteins, about liposomal amphotericin B, it's often used for aspergillosis, at least azole-resistant aspergillosis. Also in severe disease in cryptococcosis, histoplasmosis, and mucormycosis. And fortunately for this drug at least, resistance is still rare. The mechanism of action is debated. It binds ergosterol, does some self-assembly and pore formation, probably also does some oxidative damage, but it's not completely sure what this drug does, what the exact mechanism of action is, or at least the total is. But there's a nice paper on what is known. However, although it's first-line therapy for multiple diseases, it has a lot of limitations. So it's extremely nephrotoxic, can cause acute acidosis, can cause polyuria, hypovolemia, electrolyte disturbances. Also in the case of combining amphotericin B and flucytosine, they act synergistically, so you might end up with toxicity even faster. It's important to know that liposomal amphotericin B is less nephrotoxic when compared to the conventional amphotericin B, but it's more expensive, which is important in some settings. It binds fungal cholesterol and mammalian cholesterol, so it does not only bind to the fungus, but also attacks the human host. And there's also some acute infusion-related adverse events, including liver damage, so really within hours. This has also been reported. Another thing I wanted to mention is that especially for liposomal amphotericin B, penetration into urine is poor. So for urology patients, this might not be the drug of choice, or they should be combined with something else. Then if you want or have to step down from liposomal amphotericin B to something else, usually salvage azole therapy, especially in the case of aspergillosis. But salvage azole therapy is not always possible. For example, patients when they're using rifampicin, for example, on TB. Rifampicin is a potent CYP3A4 inducer, which will cause your azoles to be subtherapeutic or not measurable at all in serum eventually. And there's also hepatobiliary toxicity, which happens often with liposomal ampho B, and then perhaps there's the alternative isofluconazole, which we will discuss. And in the case of azole resistance, there's the possibility of posaconazole with therapeutic drug monitoring. There's specifically in CPAs, on chronic pulmonary aspergillosis, there's the possibility of echinocandin monotherapy, and perhaps some novel drugs like olorofil. We'll discuss a bit more on novel drugs as well. So first go into isofluconazole for invasive disease. There's a nice paper published in the Lancet in 2016. It reads isofluconazole versus voriconazole for primary treatment of invasive mold disease caused by Aspergillus and other filamentous fungi, a phase 3 randomized controlled non-inferiority trial. It's a study paper from Johan Martens, among others, and they discuss the allogeneic stem cell transplantation population with mostly Aspergillus species. And they show how, well, they show many things, but they show how isofluconazole, when compared to voriconazole, how isofluconazole has less hepatobiliary disorders, less eye disorders, less skin disorders, and less drug-related adverse events while having the same mortality. So it's actually a really feasible alternative for voriconazole, especially in the setting of hepatobiliary disorders. And there are two more papers I wanted to point out. There are more out there, but I wanted to point out these two papers. One of them is Samantha and colleagues from CID in 2021. where the tolerability of isobutanol and voriconazole prophylaxis in lung transplant patients is described, and they show discontinuation of 11% versus 36%, often due to hepatotoxicity when in favor of isobutanol. And Martin and colleagues from Lancet Infectious Diseases in 2021, they demonstrate how isobutanol showed activity against mucormycosis with efficacy similar to amphotericin B, which means in the case of, for example, double mold infections or just mucormycosis alone, isobutanol is also could be a good alternative. Some pros and cons. Isobutanol has less drug interactions, linear pharmacokinetics, less toxicity, and a broader spectrum of activity. But it is way more expensive. Long-term effects are not really known yet, but at least for what we know, it seems safe. And the skin abnormalities I haven't heard that you see with voriconazole, I haven't heard about those in isobutanol. But perhaps the other people I've present here today know a bit more about this. Now, I also want to tell you about the voriconazole and isobutanol interaction with flucloxacillin, which I think is really relevant and often missed, where the use of flucloxacillin might cause subtherapeutic concentrations of voriconazole and isobutanol. So be careful when using these combinations. There's also an alternative for voriconazole in using posaconazole for invasive disease. There's a publication from Mycology in 2020 from Agostinho, but also Verweij and Bart Rijnders, who are present here today, on high-dose posaconazole for azole-resistant aspergillosis and other difficult-to-treat mold infections. What they show is that you can use, when using therapeutic drug monitoring, you can use posaconazole still for borderline-resistant aspergillus isolates. And the current guidelines state that a trough level of above 0.7 mg per liter for prophylaxis should be used, above 1 for primary therapy, and above 1.25 for salvage therapy. And now if you use the trough levels for above 3 mg per liter for borderline-resistant aspergillus species, so either intermediate or resistant or borderline resistant, and then you can still use posaconazole. And of course, this is a double-edged sword, as it always is. If you increase the dose, you get increased toxicity. In this case, the severe adverse effects are mainly cardial, including the QTc prolongation, and also heart failure, electrolyte disturbances, in addition to the hepatobiliary toxicity you can see, or the delirium and other side effects. Specifically for chronic pulmonary aspergillosis, there's the possibility of echinocandin monotherapy. There's a nice paper from Paul Verweij, an international expert opinion on the management of infection caused by azole-resistant aspergillus species, or fumigatus, sorry. And he discusses how echinocandins have synergy with azoles, how fortunately the in vitro activity of echinocandins against Aspergillus fumigatus appear unaffected by the presence of an azole resistance mechanism. So that's good news. However, caspofungin has been shown to be efficacious for invasive aspergillosis, but success rates were disappointing, so you should not be using it for invasive disease. However, it could be an option for immunocompetent patients when they have CPA, where you have no possibility, where you have no alternatives, but you can use an echinocandin because it has a really nice safety profile. Of course, as it is the case with all of these patients, you have to follow them up really well to see if they go well. Then there's a wish for alternative antifungal drugs, and some of them are coming up, but there's a need for less toxic drugs with fewer drug-drug interactions. There's a need for alternatives in the case of intolerance, allergic reactions, and adverse events. There's a need for a better spectrum of activity, and there's also a need for better microbial species treatment because of the high mortality we know in these patients. So there are a few drugs coming up. This is the paper from Martin Hoenigl on the antifungal pipeline. It's really a must read. If you don't know this, you should. He discusses multiple drugs, including ibrexafungerp and risankizumab, which target beta-glucan. One of them is echinocandin. He discusses fosmanogepix, which is a novel drug, actually novel method of action. Opalconazole, which is an azole, but it's nebulized, so another way of administration. And there's olorofim, which is a DHODH inhibitor, which is a really promising drug. This is a figure from the paper where you can see, on the case of azole-resistant Aspergillus fumigatus, for example, you see lots of green. So especially olorofim is promising in when you have to treat molds for a long time. But all of these drugs have, and this table, this figure is more lengthy. It's even longer than I'm presenting right now. So take a look. There are many things, good things coming up. But just presenting these 5 drugs, what they might be useful for. So fosmanogepix has broad spectrum of activity. Risankizumab can probably be used for prophylaxis and extended outpatient therapy because it's an oral drug and works for about 1 to 1.5 weeks, and maybe longer. Ibrexafungerp might be used for resistant Candida species and recurrent vulvovaginal candidiasis. Opalconazole is a nebulized azole, as said, and olorofim can be used for long infections have to be treated for a long time, difficult to treat infections like azole-resistant Aspergillus species. So just looking at olorofim a little bit more, besides the azole-resistant Aspergillus species, also seems to work on the Metaspora prolificans, which is a game changer. It has many advantages and very limited toxicity. And I heard about some reversible liver test changes, but it really has very limited toxicity. Very low MICs for most molds, good distribution to tissues, including some levels in brain. It is a CYP3A4 weak inhibitor though, so rifampicin might still be problematic. But I have no experience in the clinic with this drug, so I can't really tell. Efficacy data will be published this week, so I'm really enthusiastic about those data, and I hope to hear some more this week. It's promising. Then a few concluding slides on the agricultural use of antifungals. So environmental exposure to azole fungicides, they have driven the emergence of environmental resistance mechanisms, and now the EPA, the Environmental Protection Agency, has registered the new fungicide ipflufenoquin. Ipflufenoquin is a olorofim-like fungicide with the same target. It's an inhibitor of DHODH. And actually nice work from Jochen Bal and Paul Verweij. They show how Aspergillus fumigatus with a single point mutation already can convey resistance to olorofim. So that's really sad news when the EPA allows such a drug. Now, there's also a nice read in National Geographic on the topic called "Humans Are Not Prepared for a Pandemic Caused by Fungal Infections." It's actually fun to read. So some learning points. There are many challenges faced in the management of clinical mycology cases. There's really an importance of the immune system, so never forget this. Antifungal resistance and comorbidities, they limit therapeutic options, so you really need tailored medical advice by an expert. Know the main drug-drug interactions. There will be some new antifungals soon, and we should prevent the agricultural use of human medicine-like drugs in the future. I'd like to close with a statement. The need for surveillance, given the emergence of antifungal drug resistance. So we're seeing not just azoles and Aspergillus fumigatus, but also we see Candida auris, we see Candida tropicalis, we see Trichophyton species, we see lots of drug resistance popping up in the world right now. Thank you for your attention.
Thank you so much, Eelco, for a wonderful, basically, overview touching pretty much all the topics that we will further discuss today. So I think it was a fantastic presentation. I understand that you just returned from India very recently, and thanks so much for making time, despite potentially some jet lag, just returning from a long flight. Thank you so much.
That's correct. Thank you very much.
So we have a number of questions from the audience, and let me just start off. Do you, Paul, have like one question that particularly caught your eye? Otherwise, I will just start.
Yeah, so I think there are a number of questions. Some are related to the diagnostics and some to the treatment. So maybe it's good to discuss the diagnostic questions because maybe later on we will get more into detail on treatment. So I think there are two issues. One which is questioned is how do you diagnose invasive aspergillosis in severe COVID patients? So do you use serological tests? Do you combine assays? And I think a second question, which is also relevant, is when do you consider resistance and how do you detect resistance? So in the Netherlands, of course, we are quite proactive, but I think it's also interesting just to touch on that to see in what kind of patients should you consider resistance as something you have to look into.
Right. So first on diagnostics, I also see a question here: do you use serological assays, and what do you use? So, and the question was specifically for Kappa. Was that correct?
Yeah, I think it's because of the case you presented, and there's of course a lot of debate around the diagnosis of Kappa, I think. Yeah,
that's true. So for all patients where you have the suspicion of invasive fungal disease, and it could be either clinical deterioration, it could be, well, especially in the case of influenza, you always have the suspicion when they get administered to the ICU, because the percentages are so high in these patients of influenza-associated pulmonary aspergillosis. But in the case of Kappa, the percentages seem a bit less, and also the disease seems a bit less severe. But if you have a patient that gets administered to the ICU with pulmonary lung abnormalities, lung disease, then we usually perform a BEL, so broncho alveolar lavage. Depending on the disease, the underlying disease. So for influenza, we also always do additional diagnostics in serum. As you can see, in influenza patients, you often see IAPA already at admission, while in COVID-associated pulmonary aspergillosis, you usually see after a week or a bit longer, you see disease. So once you have the patient administered to the ICU, then we usually start, if we have a suspicion of infectious disease, we usually start antibiotics. And if there's a need, we'll do the BAL. And then on the BAL, we'll do the collectometin and culture. And depending on what you find and how and the clinical characteristics of the patient, we can also do a PCR. And it's also a PCR that detects resistance mechanisms. And these are the most common resistance mechanisms that I pointed out in the slide. So the tenor repeat 34, L98H, and the tenor repeat 46, the I121Y, 121F mutations. There are methods that look for these specifically, and that's also really relevant because those are the ones you will find most often in Kappa and also in influenza. But it's really multifactorial. So if you look at the guidelines and also the international consensus and the expert opinion on which, if you look at the ERTC criteria, or if you look at influenza or Kappa specifically, then there are then what you use might be or the colors that you use might be just a bit different, but in general they're really similar. So if you're thinking about invasive fungal disease, do look at those guidelines because they outline really well what you could do.
Thank you. Thanks so much, Eelco. Maybe one last very quick question before we move on in the program. I think really a ton of thanks to all the audience for all these very interesting questions. We will really, as Paul said, try to address them as the webinar goes forward. But maybe one question about the new antifungals. Let's start with Fosmanogepix. Let's start with Fosmanogepix question. There was one question whether you would see Fosmanogepix being used as first-line treatment. And I think it's an interesting question. What are your thoughts?
So And then we're talking then about Aspergillus, invasive Aspergillus disease. So when thinking about drugs that target beta-D-glucan, like echinocandins, there for now really there is only data on in patients that you think have no immune disorder, have only CPA, for example, chronic pulmonary aspergillosis, no immune disorder, and then you could use an echinocandin because the patient has a functional immune system, and it's really in addition to the functional immune system. But in any other patients, I would not recommend using a echinocandin or echinocandin-like drug, just because we don't know. We have some data out there that that's probably inferior in the case of invasive disease. And for the new drug, I wouldn't be able to say, but for now I don't have any info on the new drug, so I would not.
No, I agree, and that's I think that's very much how we would see it for now for ibrexafungerp also, and for risafungin, and for phosphonogpics. I mean, it's hard to say also at this point whether this could be first line agent or whether this would be kind of like more for resistant, azole resistant aspergillosis, for example, where we would use it primarily. So exactly. I think, Paul, do you have one more urgent question for Eelco? If not,
no, I think it's good to proceed let's move on to the next. The only other thing is that there was a question on the benefits of interferon gamma, and I don't know, maybe Agostinho, you might want to comment on that if there's a role for that, you think?
Well, interferon gamma deficiencies have been identified in a number of patients. So the most recent example is kappa and yappa, and also people have noticed also in CPA patients. Whether it actually can be used as an adjunctive therapy remains to be tested, and there are a number of trials starting, some others are ongoing, so we'll have to wait and see.
Yeah, so there's a lot of wait and see, new drugs, new approaches, but it's good that we are getting options, so that's great.
And I just got the okay that we can answer some of these additional questions, because actually we started a bit late and Eelco is getting this additional time that we started late for the discussion, which I think is just fair. So there were some questions about basically, let's say with the new drugs for now. There were some questions about olorofim, and when this will be available. Maybe I can add to that, because I do have some experience in the drug as part of their phase 2b trial, and I also have some very recent update basically from Austria being outside of study. So currently olorofim, and maybe Paul conducted that, is running in clinical trials. There is one basically for all different mold infections, treatment-resistant mold infections where it's effective, which is not mucormycosis, but definitely aspergillosis, but which is not responding to as a treatment-refractory aspergillosis, where there's no standard of care options feasible or available anymore. And then, of course, Lumentospora infections, Fusarium infections. So a lot of rare mold infections. And the other trial that's coming and ongoing is a broader trial focusing on aspergillosis. But there's also an option if you are in a setting where you don't have access to a trial site. There is some option, I think, with olorofim and with F2G to get this drug via compassionate use program. At least in Austria, this was feasible. The only requirement is basically that your patient would need to fulfill the criteria of the phase 2b trial, which means in case of other mold infections in aspergillosis, it needs to be a proven mold infection and not a probable mold infection. So you need to have histological evidence. But I just wanted to get the word out there, because that's really a discussion I had a week ago. And if you have a patient you would think could benefit, there might be some options with olorofim. And I have not heard the same for phosphonogpics, for example, that this is an option, compassionate use. So yeah, just wanted to get the word out there. And then one more question now, really forwarding to you, Eelco, and this is about amphotericin B and therapeutic drug monitoring. Is there any role for DDM and amphotericin B to avoid nephrotoxicity? Maybe also, mention your thoughts about continuous basically injection or continuous basically IV usage via pump of amphotericin B at a continuous low dose, whether this could help in your feeling. What are your thoughts about TDM there?
So actually, no experience in TDM with amphotericin B. What we use it for is but perhaps Paul can add on that. For if you look at the indication, so depending on the fungus, you have a certain dosage that are noted in the guidelines. Now you do see with, for example, the 10 mg per kg, you see way faster toxicity than what you would see at 5 or 3, depending on on what fungus you're targeting. But also if you run into more rare fungus, then you would look at the MIC and probably delineate from there, like how sick is my patient, what alternatives do I have, is monotherapy the only option, and then you probably go judging from MIC, you would decide on a dosage. But for it's that's difficult, but for me the TDM, I don't know if anyone else has experience with TDM, but I actually don't.
No, I actually agree. And I think also for the continuous infusion, right, of amphotericin B, conventional amphotericin B, we've seen a study published, but I think at this point we really still lack larger experience for that to be, both safe and effective, right? We need both basically. And I think It's too early to kind of like recommend this approach because I think the data are just not there yet, which doesn't mean that, we could do further research. But I think we just need to wait for more data there. So,
I think there are studies indeed that, especially with the conventional amphotericin B, that show that you have less toxicity if you give it as continuous infusion, but there's no efficacy data. And I think also the PK/PD indicates that the peak over MIC is probably the best predictor of efficacy, and that's something which you won't achieve with continuous infusion. So I think we have to be cautious about that. I also saw in the questions that there is an email presented, medinfo@fgg.com, if you want any information regarding access to olorofin. So that's very useful for people if they want, if they have patients who they want to discuss or have access to a compassionate use program.
Fantastic.
That's good. Very quick.
I think that's the perfect message actually, and it's good that we have so many people joining, from different sectors, to really make this a valuable resource and a success. This webinar, I just heard we have 275 participants in this virtual webinar hosted virtually in the Netherlands, but you can see in our panel that there is some Dutch predominance, which makes absolutely 100% sense when you think about the topic here. One exception in the speaker panel is the next speaker, and it's my real pleasure to introduce Agostinho Carvalho. He's professor of the University of Minho in Braga. His background is immunology and fungal immunology in particular, but he also has a particular focus on all other and many other hot basic research questions in invasive fungal infections, particularly invasive aspergillosis. And one of them is, of course, antifungal and anti-mold resistance mechanism, basically. I'm very much looking forward to your talk about Agostinho, a translational talk about antifungal resistance mechanisms in molds.
So I hope that you can see my screen.
Yes, we can see it.
Perfect. So thank you, Martin, and also Paul, for the kind introduction and for the invitation. And also, I would like to congratulate you for this very interesting initiative. So basically, as Martin was saying, I'm more of a fundamental translational researcher. So the goal for my talk today is to basically discuss a number of very basic and fundamental mechanisms that underlie antifungal resistance, and also to touch upon some new concepts that are emerging in this specific field, which have to do with tolerance and persistence and lateral resistance and so on. For the sake of time, and also because I'm more interested and more used to deal with Aspergillus, I'll focus on some examples that I think are critical hallmarks for a number of processes that I think are critical in the field of antifungal resistance. Since late 1950s, we've been witnessing the development of a number of antifungal agents. Unfortunately, most of them belonged to very few classes. And this, of course, has somehow limited the therapeutic options that were available to treat patients. As Eelco said before, there seems to be some improvements in our horizon with these new drugs that we also discussed in the previous talk. But basically, the current scenario seems to indicate that clinical management of fungal diseases and aspergillosis in particular have been hampered not only by a lack of therapeutic options, but also because antifungal resistance has been emerging. Now, if we think about one classical example, which is azole resistance in Aspergillus, and this is highlighted here in this pivotal paper that basically demonstrated the worrisome trend of azole resistance in the Netherlands, worked by Paul Verweij. And you can see basically in blue the number of patients with positive cultures for Aspergillus, and the red line indicates the percentage of patients that had actually an azole resistant isolate. So the spread of this resistance was associated to a mechanism that involved mutations and promoter insertions in CYP51A, as was discussed before. And this is actually one of the major mechanisms that is responsible for azole resistance in Aspergillus. So Eelco already mentioned the tandem repeat 34 L98H, which is basically the most common genetic driver of azole resistance in fumigators. But I would like to draw your attention to some data in this paper here, which basically indicates or seems to suggest that in recent years, there have been an increase in the diversity of mutations conferring resistance to azoles. And actually, you can see indicated in yellow also the emergence or the expanding numbers of patients with isolates that had that were resistant to azoles due to non-CYP51A mutations. And this, of course, may explain why the number of resistant isolates have been increasing, and also the number of patients with those resistant isolates. Now, if we think about azole resistance, one important concept that Eelco also referred to has to do with the acquisition from the environment. And this has been known for a while. But a recent population genomics analysis of a number of isolates from the UK and Ireland, and this study included 153 clinical isolates and 65 environmental isolates, basically demonstrated that genetically the resistance to azoles was basically confined to a single clade here that you can see here. And again, of course, the mutation that was mostly responsible for azole resistance was the tandem repeat 34 L98H as expected. Now, what is also very interesting is that if we focus on this clade associated with azole resistance, it is pretty much difficult to distinguish environmental from clinical isolates. They are very closely related. And this again can be seen if we analyze the data, the phylogenomics data, using principal component analysis. Basically, you see that there's a very strong overlap between the clinical and the environmental isolates. So it is clear that there's acquisition of azole resistant strains from the environment. Now, classically, resistance and antifungal resistance has been described in, as a dichotomy between two events. So either we have an isolate that is susceptible to an antifungal agent. So basically, this means that it is rapidly killed by the drug. And in contrast, when an isolate is resistant, it basically survives and is actually able to grow in the presence of concentrations of drugs which are above the defined MIC. Now, this situation is becoming a bit more complex, and we'll get to that in a while with other examples. Now, in terms of resistance, and similar to what happens in bacteria, fungi can acquire it through basically two types of mechanisms. So the intrinsic resistance, which basically includes ways of hiding the target of the antifungal drug, ways of lowering the affinity of that target or lowering the permeability to the drug, besides enhancing efflux mechanisms. Now, the acquired resistance, as we mentioned already, depends on acquisition of mutations or gene duplications or duplications of gene segments that basically end up modifying the target that of the antifungal drug, but it can also inactivate the drug and also lead to enhanced mechanisms of drug efflux. Now, these mechanisms of antifungal resistance, they have specific mechanisms associated to each antifungal class, basically. So I'll take advantage of this very nice review that was published recently in Nature Reviews in Microbiology to basically go through very quickly some of these well-known mechanisms according to each class of antifungals. So basically, in the case of azoles, most of the mechanisms are indicated here. So in the case of Candida, it typically is associated with an increased drug export through the overexpression of efflux pumps. In the case of Aspergillus, it has to do with the reduced binding of the azole to its target by, promoter and other mutations in CYP51A, basically, which is a gene important for ergosterol synthesis. And other fungi, such as Cryptococcus, they have different mechanisms that rely, for instance, on the overexpression of the drug targets, either through chromosomal aneuploidy or also hypermutation. Now, in the case of polyenes, and Eelco also mentioned this briefly before, so polyenes, basically, they compromise membrane integrity by forming these polyene ergosterol complexes. And basically, the mechanisms of resistance that emerge are due to loss of function mutations in ergosterol biosynthesis. And this is classical for both Candida and Aspergillus. Now, in terms of echinocandins, the target is 1,3-beta-glucan synthase, and resistance mechanisms include mutations in the gene that encodes this synthase, FKase1, and this is typical of Candida. And interestingly, the treatment with echinocandins also induces a number of cell wall stress and stress response pathways, for instance, related to heat shock protein activation and calcium-calcium signals. And these are actually signals that are involved in drug tolerance, as we will see also for the case of Aspergillus afterwards with regard to calcium signals. Finally, pyrimidine analogs such as 5-flucytosine, they basically inhibit DNA and RNA synthesis. So basically resistance emerges through point mutations in the target, the cytosine deaminase, FCY1, and other fungi such as Cryptococcus, they resort to hypermutation basically to circumvent the toxic effects of these drugs. Now, if we go back to the azole resistance, and of course, we are now pretty much familiar what are the molecular mechanisms that, for instance, are responsible for the resistance in the strains that carry CYP51A mutations. However, there are a number of isolates that now are starting to appear with new mutations or even with mutations outside the CYP51A locus. So one way of, trying to understand what is the molecular basis of azole resistance is basically to try and identify regulatory targets for that resistance. And this was what was done by Mike Bromley and his team in a paper published 2 years ago now. But basically what they did was to resort to this library of transcription factor null mutants of Aspergillus that they have generated, and basically they screened the whole library for susceptibility to azoles, in particular itraconazole. And basically what they found was that upon exposure to very high concentrations of itraconazole, there were 6 regulators that were identified to be involved in resistance. And interestingly, 4 of them were actually identified or associated with azole resistance in fumigators for the first time. And you can actually see the impact of that resistance, particularly for the NCTA and NCTB mutants here, with very high MICs for itraconazole, voriconazole, and posaconazole compared to a wild-type strain. And also not shown here, they also display increased resistance to other classes of drugs, such as amphotericin B and terbinafine. Now, from a mechanistical point of view, and of course, I'm not going to detail all the approaches, biochemical and morphological approaches that have been developed, but basically the phenotype of these 2 relevant mutants was associated with a transcriptional dysregulation of the ergosterol biosynthetic pathway, with increased cellular ergosterol levels. You can see here the quantifications in these 2 mutants compared to the wild-type strain or the complemented strain. And also, very importantly, these mutants, and particularly NCTA, also displayed increased expression levels of the CDR1B azole transporter. Now, interestingly, and this is in line with what has been observed also for the classical CYP1A mutations, these strains are not more virulent when they are used in animal models of infection. Here, 2 different models, leukopenic and cortisone acetate treated mice. So drug resistance, but no increased virulence in animal models. So basically, there's a model for the role of this novel complex in antifungal resistance, which is basically due to their role in secondary metabolism, cellular transport, but also ergosterol synthesis and efflux pump expression, that basically upon the removal of these factors of this complex, what we observe is that there's an increased production of ergosterol and also an expression of the azole efflux pump CDR1B that basically explains the multi-drug resistance of these strains, and actually very interesting also to salvage therapies such as amphotericin B and terbinafine. Now, upon exposure to these antifungal agents, in particular azoles, fungi undergo a number of stresses, basically, and they have developed ways of coping with those stresses. And one of the perhaps most well-known ways of dealing with those stresses is the activation of calcium signals and calcineurin-mediated signals. Now, what is very interesting is that from a biological perspective, the mitochondria is an organelle that is very important in maintaining calcium homeostasis. So this is interesting because these type of signals can be viewed as potential adjunct targets for antifungal therapy. Now, in this study, what has been done was basically to generate a number of strains with point mutations in COX-10, which is basically a very important regulator of mitochondrial homeostasis. Now, the first interesting finding is that some of these strains with these point mutations, they display a very poor growth, even in normal conditions. And actually, this defective growth is also associated with a lower virulence when these strains are used to infect, in this case, a Galeria model. Now, what is very interesting is that despite this defective growth in normal conditions, upon administration of very high concentrations of itraconazole, actually these strains not only survive, but they also start to slowly grow. So this means that somehow they tolerate the presence of itraconazole and they are able to grow. Now, to understand what the mechanisms are behind this tolerance to itraconazole, what these authors have done was to run transcriptomic analysis by comparing a COX-10 deletion or the point mutation here identified. And basically what they found when comparing these transcriptome to the wild type strain is that there's a massive upregulation of a number of genes that are typically associated with antifungal resistance, besides a number of genes involved in chitin synthesis. So basically, this seems to suggest that mitochondrial homeostasis and calcium signals are important for azole resistance and could be potentially perceived as adjunct targets in antifungal therapy. Now, what is interesting is that if these strains are also subjected to calcium pulses and the, let's say, the flux of calcium in the mitochondria and the cytosol is quantified, we can see that these strains with the point mutations, they have lower levels of mitochondrial calcium, but higher cytosolic transient levels of calcium. And this basically suggests that indeed calcium is dysregulated in the strains with these mutations. Now, what is very interesting is that calcium, as I mentioned, regulates calcineurin, and calcineurin is important for the activation of a transcription factor, which is CRZA, which is a transcription factor that regulates a number of target genes involved in antifungal resistance. And actually, by basically looking at the cellular localization of CRZA, it is possible to see that in the COX-10 deletion strain, this CRZA has a nuclear localization, as you can see here in light blue. So this means that whenever there's a mitochondrial dysregulation, a calcium imbalance, CRZA actually is translocated to the nucleus where it regulates gene expression. Now, it is also very interesting is that in these same conditions, if these strains are treated with, here in this case, BAPTA-AM, which is a calcium chelator, CRZA is no longer translocated to the nucleus. So theoretically, there will be no expression of genes associated with antifungal resistance. So in terms of this study, basically the model implies that upon these stresses that are induced by azole, there's a mitochondrial dysregulation with calcium also imbalances that will lead to the activation of CRZA and its translocation to the nucleus, where it will activate a number of the expression of a number of genes involved in antifungal resistance. Now, what is important also from a therapeutic perspective is that calcium chelation in these conditions may also basically prevent the activation of these stress response mechanisms in the fungus and basically overcome the ability of the fungus to resist these stresses during antifungal therapy. Now, we've been discussing a little bit about resistance and tolerance, but do fungi rely only on these mechanisms to withstand the action of antifungals? So as I mentioned in the beginning, the situation seems to become a little bit more complex. And I'd like to, go through a very recent example that describes the existence of persistence in Aspergillus. I'm not going to focus, for instance, on heteroresistance, but there's also a very interesting recent study by Tobias Hall describing heteroresistance in Canada and how it impacts clinical practice. So I also invite you to go and take a look at this work. But basically, what I wanted to use as an example for persistence is a very interesting so before that, I'd like just, to give you a brief overview of this mechanism. So I mentioned in the beginning that there are basically two extremes in the spectrum. One has to do with susceptibility to a drug. The other has to do with resistance. But of course, we also have tolerance, in which you can see the curve here. Basically, the classical curve is in green, which is basically a substantial proportion of cells in a population, in a susceptible isolate, that are able to grow in supramic drug concentrations. Then we have persistence, which I will approach afterwards, which is very similar to tolerance, but in that sense, just a very small fraction of the population is able to survive and grow in the presence of supramic drug concentrations. And finally, heteroresistance, which I will not address, but it's basically a very transient capacity of a subpopulation to increase the MYC due to very specific adaptations, epigenetic modifications, or also chromosomal aneuploidy. So as I mentioned, basically I wanted use this as an example of the existence of persistence in Aspergillus, and how this can also be important to explain, in this case, azole therapy failure. So this is a very nice study that is still in a preprint version by Jorge Amish and colleagues. And basically what they did was to basically analyze susceptibility of a number of strains, from environmental strains to clinical isolates, lab strains, and also one resistant control with a tandem repeat 34L98 mutation in CYP51A. And basically by evaluating, you know, susceptibility to voriconazole, they found, of course, by using this diffusion assays, they found that some strains identified here as susceptible, they displayed very clear inhibition halos. As you can see, the resistant strains did not display any type of inhibition halo whatsoever, as one would expect. But, you know, among the strains that were tested, 5 of them actually displayed this phenotype that you can see here indicated in the red arrows. So a number of very small colonies emerged in the inhibition halo. So this means that a number of cells are able to withstand voriconazole, these very high concentrations, and basically to grow slowly in these conditions. And actually you can see here how they classified these strains as persisters based on the original MICs that were defined for these strains, but also the MICs for the colonies that were isolated from the inhibition halos. And as a curiosity, it's interesting to note that these 2 strains identified as persister were actually 2 environmental strains. Now, what is also very interesting, and this is actually another measure of persistence, is basically that if we grow these colonies in liquid media, we can see that, of course, there's a very marked decrease in viability of conidia. But in any case, this is basically percentage of the viable conidia with respect to the initial inoculum. You can see very lower values. But in any case, the persister strains here identified in red are actually the ones that display higher viability in these conditions. And actually, if analyzing, you know, the kinetics of cell death, it is possible to observe that, of course, there's a marked reduction in viability in the first 24 hours. The susceptible isolates are actually basically killed within the first 48 to 72 hours, but instead the persister isolates identified in red, they can actually survive for extended periods of time. And this gives rise to this very characteristic biphasic curve, which is typical of a phenomenon of persistence. Now, very interestingly, a number of stresses that are applied to these strains do not seem to influence persistence. So hydrogen peroxide, detergents, sodium chloride, chalcofluor white, with the exception of hypoxia. In conditions of hypoxia, persistence seems to be abrogated, and we can discuss this afterwards. But also interesting, nutrient availability. So if persistence is evaluated in a rich medium, culture medium, such as PDA, the number of persister colonies that emerge is much more frequent than those that emerge in tests done in minimal medium. And actually not shown here, but it's very interesting that if a rich media is used in conditions of hypoxia, hypoxia actually dominates over nutrient availability and prevents the emergence of persister colonies. Other interesting results that I'm not going to detail is that the combination of voriconazole with caspofungin or amphotericin B does not prevent persistence in response to azole. And of course, persistence is not observed only in response to voriconazole, but also to other azoles. Now, in an attempt to understand a little bit more about the molecular mechanisms that were driving persistence in Aspergillus, what the authors did was basically to run the transcriptome analysis of these persister strains. And basically this represents what they found as relevant in terms of the genes that were being upregulated. And I would like to draw your attention to the upregulation of galactose metabolism and the biosynthesis of galactosaminogalactan, which is a very important component of the fungal cell wall, but also sterol metabolism and secondary metabolism. Actually, among the genes that were mostly upregulated, there was CYP51A and also the efflux pump CDR1B. Now, although one would expect a role for these players in sterol metabolism, the novelty perhaps in these data was related to these impact in GAG biosynthesis, for instance. So in a very simple experiment, what the authors did next was to basically run the persistence experiments, but also at the same time treating these cultures with galactosaminogalactan. And there seems to be a mild improvement in viability, although one, of course, may argue about, the biological validity of such a very small difference. But in any case, this seems to suggest also a very important important role of GAG in this process. And of course, it supports additional studies in this matter. Now, in similar to what has been described for the CYP51A mutations and also for the mechanisms that I showed before that were involved in tolerance to azoles, also these persister strains were not more virulent in a Galeria infection model, so they were very comparable with these other strains. But what is perhaps more important is that if the fungal burden is somehow quantified, it seems that in the presence of voriconazole, actually they tend to, kind of maintain the fungal burden, whereas the susceptible strains, they actually almost do not survive. And this can be nicely quantified by the ratio between the burden observed in the presence of the drug and in the absence of the drug. So lower ratios basically mean higher fungal burdens in the presence of the drug. And this may, to some extent, also help in explaining why sometimes it is clinically observed the therapeutic failure of these azole treatments. Now, to conclude, basically, I'm not going into detail about the type of interventions that we can have in terms of, of targeting environmental fungal resistance or resistance in the clinical practice. But I would like, basically to stress that, a better understanding of the molecular and also cellular mechanisms that are involved in the development of antifungal resistance may be critical. So I mentioned a few, for instance, to target stress response pathways apart from the action of the antifungal drug may represent very interesting approaches. And this basically would be considered as very well defined here, a resilient treatment in which we are combining basically the action of an antifungal drug with the action of a molecule to basically somehow compromise the ability of the fungus to cope with that stress. And in the previous talk during the Q&A session, we also mentioned about the role of cytokines and other inflammatory mediators. Of course, there's also a role for these molecules to somehow boost the immune system and to be used in a concerted action against, fungal infections and particularly fungal resistant isolates. And with this, I'm done with my talk, and I'm happy to thank you for your attention. Happy to take your questions.
Thank you so much. I can't start my video, but I think everybody can hear me now. It works. Thank you so much, Agostinho, for a wonderful talk. We have a few questions, and before we start in a discussion, I would just want to, because there's been some confusion about my particular responses to continuous amphotericin B, conventional amphotericin B infusions, and some questions, what about liposomal amphotericin B and ambisoma? And of course, the discussion back then was really focused only on conventional amphotericin B. And if you are in a setting where liposomal amphotericin B is available, this would of course be the option that we were referring to, or the alternative that we were referring to, that is very well established. And that was also our point there. On the other hand, if you happen to be in a setting where the only drug available is conventional amphotericin B, the situation may be different. So just to clarify this, of course. But now jumping into discussion, and I think there were a number of very good questions. First, maybe going into this will overlap, it will basically bridge towards the next talk. But the question was, could an increased dose or treatment duration overcome this persistence to voriconazole that you see in some of the Aspergillus species?
So, I mean, from what is reported, persistence is also a transient effect that occurs during a certain period of time. But if the dose that is applied continuously, then viability continues to decrease. I'm not aware whether, in these conditions, it is possible to completely eliminate all surviving cells in a way that persistent does not stays and basically leads to the emergence of these strains after, for instance, removal of the treatment. So, but clearly, I mean, with the use of the drug for extended periods of time, after an initial period in which the fungus is able to survive and somehow cope with the drug, it starts to lose viability. It is not clear, and it's very difficult to quantify in a very, precise manner, because, at a certain point, we are just referring to, 0.01% of the population. So it's very difficult to quantify persistence. And I'm guessing that this is, in the clinics, this might be, a challenge in that sense. But yeah, so that's.
And I might just add on a second question, because this goes to you and Paul as well as my co-chair, I think, because Paul may also be, in a very good position to answer these questions. So these were all relating basically to the different frequency we are seeing azole-resistant aspergillosis and fluctuations between 2000 and 2007, and then also the peak in 2010. So how can this be explained? And I don't know, Agostinho, if you want or you wanna.
No, I think Paul.
Paul will be the perfect person to answer this. That's why I think so. Paul will be the perfect person to answer this. Yeah.
Yes. Well, thank you. That's a great question. I think that's something that we've seen when we've looked at the resistance, and especially in the early years. So I think this is really due to the fact that we have relatively low number of patients with resistant isolates in that time, and that's, you might have 2 or 3 patients in 1 year, and then the next year you might have 5. And so that kind of variations already impact directly on the percentage. And we see in later years, actually, that the variation is also lower. And also, if you combine with multiple centers, you also see that the overall variation is lower. Although we do see that there's clear variation between centers.
Thanks so much, Paul. One more question about persistence, because we're talking so much about persistence. Is there any difference between the different azoles, Vori versus Isavu versus Posaconazole?
So, I mean, for the 2 environmental isolates that were, defined as persisters, they basically did not find any difference in persistence to azoles. So they persist to all types of isolates. And what is interesting is that they actually are able to maintain persistence to azoles, even if they are, treated also in combination with amphotericin B or caspofungin, for instance. So yeah, persistence seems to be a broad phenotype in response to azoles.
Great. So
okay, I think we have to move on, Martin, to the final presentation, and it's my pleasure to introduce Bart Rijnders, who is an infectious disease specialist who works at the Erasmus Medical Center in Rotterdam in the Netherlands. Bart Rijnders has a broad interest in infectious diseases and has conducted many clinical trials also in patients with COVID. But he also has an interest in fungal diseases, especially aspergillosis. And he has conducted a lot of work in the area of molecular diagnosis of azole resistance and Aspergillus diseases, and also in clinical trials in treatment. And he has hands-on experience in treatment of patients with azole-resistant aspergillosis. So that also will be his topic today, to discuss the therapeutic options and strategies in patients with resistance.
Thank you. I think you can see my slides now.
Yeah.
Okay. So back to the clinic now, where I will, as said, focus on resistance in clinical practice, and more specifically in Aspergillus fumigatus, and what we try to do in the context of the Netherlands to improve the outcome. I work in the University Hospital in Rotterdam. It's a brand new hospital, and this again reminded me of the importance of context, because after we moved to this new hospital, the incidence of Aspergillus really decreased. As you can see here, some parts of the old hospital are still in between the new hospital, and my context has changed again, because this is what I see from my office. So they're demolishing the old hospital, so the incidence may start to increase again in the near future. These are the topics that I will discuss, and I'll move forward. First, reminding you of the context. In the Netherlands, Aspergillus fumigatus is the most frequent species. Most of the patients are culture negative, if in particular in the hematology setting, and 10 to 15% of the fumigatus is azole resistant, and the two mechanisms have already been discussed that are mostly responsible for the resistance. So the diagnostic toolbox that we're using is expanding. We're using culture and morphological ID. The VIP check that was developed by Nijmegen, we're using as well, where you can screen for itraconazole, posaconazole, or voriconazole resistance, and we have it confirmed using the UCAST method. Of course, we use imaging, and we have several PCRs that we use as well on a daily basis. An in-house PCR that distinguishes between Fumigatus flavus and other species. Also a commercial PCR that we can use. And for resistance, we use an in-house PCR when we have the culture that is positive. When we do the PCR direct on BL fluid, we tend to use the commercial one, because we have previously validated it on BL fluid, and we're still doing that for the in-house PCR. Sometimes also very, very useful is the Mucor PCR that you can also do on blood or serum or plasma. And sometimes sequencing can be very informative as well. And as another diagnostic tool, of course, the antigen tests, and actually therapeutic drug monitoring can be a diagnostic tool as well. If the serum levels are very low, it can help in understanding why treatment is failing. The therapeutic toolbox, I'm not going to extend on it because it has been discussed extensively. Only mentioning that, except for these, sometimes we also use study drugs, and most recent years that was olorofim for azole-resistant Aspergillus. So I think I always prefer to use cases, and I selected two recent cases that I think are informative. This unfortunate woman was eventually transplanted because she had relapsed lymphoma. Then she had graft versus host disease and was treated for that, and with a complete remission of the GVHD. But then the end of 2018, she was readmitted with diarrhea and vomiting and this turned out to be a relapse of the GVHD. So she was treated again with prednisone, and she was discharged. And then 6 weeks later, in the outpatient clinic, she complains of thoracic pain. A chest X-ray was done, and soon after that, as you can imagine, a CT scan was done, which showed several abnormalities. The patient was admitted to do a bronchoscopy with lavage, and we started with voriconazole orally with TDM and liposomal amphotericin B, and actually antibiotics as well, while waiting for the diagnostic tests to come back. Serum galactamin was strongly positive, and unexpectedly, galactamin in BL was negative, but we did some more tests, and the culture was positive. The PCR was positive as well, and because the species and the fumigatus PCR was positive, we can conclude that it was a fumigatus infection. This patient was unfortunate because we also detected the resistance mutation, and as you remember, we also saw this CT scan, which reminded us of a reversed halo sign. We also did a mucor PCR, which also turned out to be strongly positive. So this turned out to be a mixed infection with an azole-resistant strain. This is the EUCOST result, where you can see that the voriconazole and isovuconazole MICs are elevated. Same for posaconazole, but the MICs were still on a level that we may be able to achieve. So the patient was admitted. We started with combination therapy, and then we discontinued voriconazole in this patient. And what often happens is that kidney went down rather rapidly. So after a week of 5 mg per kilogram, we decreased the dose, which seemed to work for the kidney function. And overall, this patient did well. She was admitted for 3 weeks, and then she was almost ready for discharge. And so we were asked how we would treat this patient in the outpatient setting. Remember that this was the EUCOST result. So together with the observation that the kidney function started to decline again, we decided to treat her with posaconazole in the outpatient setting, where we were aiming for high serum levels, as already discussed by Eelco, which with the tablets that we use now is often possible. Here you see the serum levels that we reached 3 or a little bit higher, but it's really important to monitor these patients carefully, because this is not always without side effects. There have been several reports on pseudo hyperaldosteronism, so you have to monitor your electrolytes and blood pressure, and occasionally you can also get myocardial dysfunction or even heart failure if you're not careful. This has been described a long time ago with itraconazole as well. But if the alternative is to continue amphotericin B in a patient with a very poor kidney function, we tend to prefer. So this is how it went. The patient was treated for a very long time with posaconazole, also actually as a secondary prophylaxis, because she was receiving treatment for GVHD. So that's a case, and now maybe some results from observational trials that we did, always multi-center, because invasive aspergillosis continues to be a not so frequent infection. So we have to collaborate if we want to learn more about the best possible approach. First of all, what is the impact of azole resistance? The first clinical papers were very, very invasive, very high mortality, but possibly there was a bit of a publication or selection bias, because these patients were typically proven cases, and they tend to have a worse outcome than the probable cases. So in a second study, several university hospitals in the Netherlands worked together to get a better idea of the impact of azole resistance. So here, in the years 2011 to 2015, patients with a culture positive Aspergillus infection were treated. And the outcome was studied in a retrospective way. So eventually, 37 cases of azole-resistant Aspergillus. These patients were all treated in real life, so they received typically voriconazole, and then the treatment was changed when the resistant result became available or when there was clinical treatment failure. And it again turned out that azole resistance was related to a higher mortality. And this was the case in non-ICU patients. Patients with invasive aspergillosis are very difficult to treat, also if they're having azole susceptible strain. So the outcome was actually not different when there was resistance, and that has to do with the very poor outcome in ICU patients with Aspergillus in general. But I think that the most important thing we learned from this study was that even within the context of the Netherlands, where there was awareness of resistance of the problem, it took a long time before the treatment was changed to typically liposomal amphotericin B, because it takes time to do a BAL, to culture, and to get the culture result back with the susceptibility result. So the question we can ask then is can we improve this outcome? Would be responding more rapidly to the results of the testing, or use better diagnostic tools like a PCR that will take less time than a culture and a susceptibility test. First of all, we did this study again with several other hospitals where we wanted to see what the outcome was of Aspergillus when resistance was detected by PCR and not by culture, because a positive culture is rather the exception, and we were not yet sure that a positive resistance test by PCR is really predicting treatment failure. So that were several questions we still had. Is detecting resistance with PCR, is it predicting treatment failure? If you treat with an azole, you would say yes, but let's show it. And is it then associated with mortality? So to do this, we went to centers that had leftover BL fluid of patients that were treated in the past with azole, so that we could test for resistance on these lavage fluids. These patients had a probable invasive aspergillosis and all received azole monotherapy as the initial therapy. And eventually we had 50 patients with an azole susceptible strain. We excluded some patients, as you can see here, and we also decided in the protocol that we would only evaluate patients that had received at least 5 days of azole therapy, because it's difficult to say if the treatment is failing if a patient did not even receive several days of treatment. So eventually we could compare 50 patients with a susceptible strain that were receiving azole therapy as a first-line treatment, and 8 patients with PCR-detected resistance that received azole therapy as well. And again, we found that detecting resistance, so retrospectively, predicted treatment failure and was associated with an increased mortality. So if you see all these results, we were wondering in the Netherlands what would be the best approach, and that's also what we discussed when we were updating the guidelines in the Netherlands about treatment of Aspergillus. Two approaches that you can choose from. You can be very defensive and start combination therapy in all patients, because as I showed you, in some centers it will take a long time before you have your result back, and if you wait up to 10 days to switch your treatment, it may be too late. So that's the de-escalation strategy. Rule out resistance, and as you have not ruled out, you give combination treatment. The other approach would be to start azole therapy. You do everything you can to get a resistance result as soon as possible, and then you escalate to another treatment when resistance is documented. So the last strategy, where you start with monotherapy, you do everything you can with your diagnostic tools, is something we studied in a study that was very recently completed. In fact, the centers that participated were all going to use the PCR. So it was some kind of implementation study where the PCR was done in all these centers. And we hoped that by using this PCR in a real life setting, real time, that we could improve the outcome and still use azole monotherapy as the first line treatment. So the inclusion criteria were hematology patients. So they had a host factor, they had a pulmonary infiltrate, and a bronchoscopy was being done or had just been done, so we could test for resistance. Patients had been on azole therapy for less than 96 hours, and the culture and galactomannan was done on site, and the PCR was done at our lab, and then we reported the result back to the clinic. So eventually it took us 4 years to include 323 patients. The typical hematology patient considered at high risk for fungal disease, as you can see here. And this is, I think, a first important result. You can see that some of the patients with probable invasive aspergillosis had a positive culture, but it was, again, as can be expected, the minority. Others had a galactomannan that was positive or a PCR, and also a large group had galactomannan and PCR positive, but were culture negative. So it seems like using several diagnostic tests can help to diagnose aspergillosis. And then the second observation we made is that when the galactomannan levels increase, let's see if I can change this bit. When the serum galactomannan levels increase, the PCR is also more often positive. So in the subset of patients with the galactomannan in BL fluid above 1, 70% of the PCRs were positive as well. And of these 37, in 37 we could demonstrate that there was Aspergillus fumigatus DNA present, and resistance PCR was successful in most of them. Sometimes you have a PCR that is positive, where the species PCR is positive, but the fumigatus PCR is negative, and there are two possible reasons for that. Sometimes the load is too low, and because the species PCR is a little bit more sensitive, it still can be a fumigatus infection. When you have a PCR that is positive with a very low CT value, a species PCR, I mean, then it typically is another Aspergillus species like Flavus or Tubingensis. So of these 323 patients, over a period of 4 years, we eventually detected resistance in the CYP51A gene in 8 patients, and we had pre-specified in the protocol that we would only look at the patients with without a mixed infection. So we had to exclude 2 patients, because if you detect azole susceptible, you detect mutated strain and a susceptible or a wild type strain, you don't really know which one is causing the infection. So that's why we predefined to exclude these patients. So how did the patients do? So the 6 with azole resistance documented by PCR and confirmed by culture in all that were culture positive. I have to say that there was one patient where at first the phenotypic test showed azole susceptibility, but then a second culture a week or 2 later showed the resistant strain as well. So eventually, what was the outcome regarding treatment failure? 2 of the 6 patients had treatment failure, which is comparable to what you see in the phase 3 studies. And none of the patients died at week 6. This will probably be a coincidence that it was 0, but it was not the 80% that was reported 10 to 15 years ago. So I think this is also not the truth. Of course, it will be something in between, but studies suggest that when you use all possible diagnostic tools that you have, that you may be able to improve the outcome of these patients. Finally, an observation we also made that I think was interesting is about the value of the PCR. It was one of the questions I saw in the chat box. So patients only had a PCR that was positive. So they were culture negative, galactomannan negative, but they had a positive PCR. And remember, they were all hematology patients that had an infiltrate on the CT scan, because otherwise you would not do a bronchoscopy. And the mortality in this group was 14%. It was not higher than the triple negative group. So that was galactomannan culture and PCR negative. Of course, most of these patients received antifungal therapy, as you can see here. So the treatment may have helped to get to this low mortality. But galactomannan was predicting a higher mortality, which has been reported several times in the past. So I'm still not really sure what the meaning is of a positive PCR in BL. And something that is maybe also relevant to mention here is that of the 18 patients where the Aspergillus PCR was positive, but the resistance PCR was unsuccessful and the culture was negative, the majority of these patients were treated with azole monotherapy, and the mortality was comparable to what you see in the azole phase 3 studies. So a second case that I thought was illustrative and good to discuss is this female patient. She was admitted not so long ago for a new leukemia and treated, and she had a lot of toxicity. She was admitted for a second course of chemotherapy in February, and actually at the end of March she was still admitted because repopulation was taking a really long time. She had typhlitis, so she was receiving antibiotics, and a CT scan of the abdomen was done to re-evaluate the situation of her typhlitis. And then you get more than just the CT of the abdomen. The upper or the lower parts of the lungs are scanned as well, and this was what was seen. So a CT scan of the complete lungs were done as well. in this patient, and unfortunately, this was seen. So we did a bronchoscopy, and galactomannan was 12. The PCR was positive with a fumigatus strain, and we did not detect resistance with the 10-repeat-46 mechanism, but the 10-repeat-34 PCR was unfortunately inconclusive. And we had serum galactomannan was positive that we could follow, so we decided to continue with azole monotherapy. And monitor the patient carefully. So a week after monotherapy was started, galactomannan was going down, not the way I would hope it to go, but it was going down. We typically recommend not to do a new CT scan until 2 weeks after the start of treatment, but sometimes it's done earlier, like in this case. It was 9 or 10 days after the start of azole therapy. And this patient was still in the hospital, still sick, but stable. But the CT scan was not better. It was increasing in size. But this can happen during the first week or 10 days. Serum levels of voriconazole were good. And because the galactomannan had been decreasing, we decided to continue with voriconazole monotherapy for some time. Then still 5 days later, the CT was repeated again, and progression was even more obvious. So we added liposomal amphotericin B, and we tried to do a new bronchoscopy. It was not successful at first because she couldn't tolerate it. Then she was, we did a second attempt with the anesthesiologist helping us, and there we found that the galactomannan was still 7. Fumigatus PCR had become negative, but the species PCR was positive and was strongly positive. And eventually we sequenced DNA and detected that it was a second infection or a mixed infection with the Aspergillus tubangensis, which can be less susceptible to azoles. So the ambisome was continued, actually the voriconazole as well, and the patient improved, and then was switched to 3 times a week, the outpatient setting of amphotericin B, something we occasionally do if we have to continue treating these patients for a long time outside of the hospital. And here we did not have the strain to do a phenotypic susceptibility test, so we were not willing to switch her to posaconazole, although that could have been an option. Then a question we got from the clinic several months after this was started was if they could discontinue the ambisome. Well, the CT scan was very much improved, and we said, yeah, I think you can discontinue because this patient was not immunocompromised anymore. And they repeated the CT another month after that. This was so a month without treatment. And yeah, we consider this scarce, and we recommended to at least consider using posaconazole prophylaxis when she would go for an allogeneic cord blood stem cell transplantation. Just a few words on this tubangensis species of the Niger complex. Actually, more recently, we had another patient which unfortunately did not survive with the tubangensis. They can be less susceptible to voriconazole. And if you here look at the posaconazole wild type distribution, sorry for this. They are, the most typically 0.125 or 0.25, so probably treatable. If you look at the voriconazole distribution, they are a little bit higher. So that may explain why the treatment response was not so good in this patient. So in conclusion, treating patients with invasive aspergillosis in the Netherlands is not just another walk in the park. Sometimes often it is not. Despite all the tools we have available, in 2/3 of the hematology patients with a pulmonary infiltrate considered at high risk for invasive fungal disease, test results are negative. So that can also help to de-escalate treatment, because often antifungal therapy is started before all the diagnostic tests are available. So it's not that because all these results are negative that the bronchoscopy was not needed. Mixed infections, they occasionally happen, so take it into account. And on a population level, the impact of azole resistance remains relatively small, but the impact on the patient level can be very substantial, because long-term IV treatment is needed, or you have to treat off-label with high doses of posaconazole and monitor for toxicity very carefully. And the mortality is increased. Even if it's not 80%, 50% mortality is, of course, also a very high mortality. And then finally, the clinical significance of an isolated positive PCR in BL remains difficult for me to really interpret. So it's good to know that it's not it's not predicting a very poor outcome, but what it really means is uncertain for me. So the last slide is my Diagnostic and Therapeutic Toolbox. I'm not going to discuss this, but I think there are many more improvements to be made in the future. And this is my last slide. Thanks to a lot of people that helped me to get to these results. Let me stop sharing my.
Thank you so much, Bart. Big virtual applause. Great talk, fantastic talk. A lot of important messages. I think one of the important ones we got was that there are mixed infections, and not for all Aspergillus actually. Azoles may be first line, even if it's not kind of like, a sole-resistant Aspergillus fumigatus, but there may also be cryptic species and other species where azoles may not be actually first line. So it's important to do the species identification always. There was in line basically one question from the audience, if I may just start a discussion. And that was specifically on how often do you see patients with mixed infections, and particularly azole sensitive and resistant strains? Is this something occurring very, very rarely? I mean, we're always thinking, do we always detect these patients, right? That's the other part. We may see that more often than we are able to detect them. But what is your feeling on how often this does occur?
Well, I think it's not so rare. First thing you have to do is to really look for this mixed infections. If you're doing phenotypic resistance testing and you're only picking one of the colonies, you will often miss it. So that's the first step. And Paul, of course, or Eelco, correct me if I'm wrong. And then if you're using PCR, you will also have a higher chance of detecting mixed infections. So the problem often is that you don't know which one of these strains is causing the invasive infection. Maybe both, but you take the resistant strain into account if you detect a mixed infection.
Thanks so much. And I think in line, there was also discussion, when do you find this, right? I mean, sometimes we see patients where basically the resistant strain is kind of like selected out by antifungal therapy, right? So we see the second basically strain cultivated later when the first strain is basically dead or covered by antifungal therapy. So yeah, I think there's different modes, but sometimes we also see both. And that's why it's so important to even consider that and think about that, especially if you have different morphology, for example. Really think about that. That might be two different Aspergillus species. Paul, do you want to continue with some questions? There's a lot of questions for Bart.
Yes, there are a lot of questions, and thank you, Bart, for this very nice overview and also the clinical challenges. There's one question about what would be the optimal resistance testing, and I think also in that question you indicate that you do multiple tests, and I was also interested to know how do you manage that if the results are not in accordance with each other. So you might have a single positive PCR, which you indicated, but the galactose is negative. How do you manage that in clinical practice?
Yeah, that's difficult, especially if you have this patient with a CT scan that is not so typical, and then you have a galactose that is negative, but the PCR is positive, and or the opposite. You have, like we had this week, a patient with a typical CT and a galactose of 1.5 in the BAL, negative in serum, in the PCR completely negative. What to do? Start combination therapy, monotherapy. I think what I try to do is really take everything into account. If it's a single pulmonary lesion, then and the patient is not very sick, so you have some time, and you really watch the patient carefully. Also by repeating the CT, we sometimes use azole monotherapy despite the 10 to 15% azole resistance, as other physicians in the Netherlands tend to do. That's what we saw in this Azerman study, that if the resistance test is not successful, often we still treat with azole therapy, and the outcome was not worse than was generally reported. But as you can see, the longer my answer is, the more I struggle with this as well in the clinic. So yeah, I hope that we can improve the culture result. So we're typically culturing like a small volume of a BAL. If we would culture like everything we have, would that improve the result? Or something we're going to test is if we do the DNA extraction on a larger volume, will that help? Yeah, and if we're really uncertain and the patient is critically ill, we take resistance into account and we treat with combination therapy.
Yeah, the increased volume has proved useful in the chronic pulmonary aspergillosis. Yes, yeah. So I think it's a good idea to also look at that in the invasive aspergillosis patients. So if you want to improve the PCR, do you have a wish list for that as well? Because you also showed in your Azerman study that sometimes it's negative, even if the Aspergillus species PCR is positive.
Yeah. An automated system for DNA extraction on larger volumes, for instance, because the lab tells me if we want to do that on 10 cc, you have to do it manually. That will take time. But yeah, if in these patients we start with combination therapy, we have time. They can have a week or 10 days before the patient is discharged. So I would say take your time and yeah, try to get to a result. Yeah, I'm not a molecular specialist, but the sensitivity of the resistance test is suboptimal for sure.
And just in line, maybe final question also with PCR, the impact of antifungal therapy, and if you have seen basically a negative impact on PCR performance, specifically beta-tubulin PCR. Question
I don't think that's really causing the lack of sensitivity. No, I don't think that's a major issue.
Okay. Thank you so much, Bart. Thank you everyone for the great discussions. There's indeed a high number of questions that have not been answered, and this is just to Healthbook and the organizers. If there's a way to kind of like forward these questions to the speakers, basically to make sure that the audience is getting some answers for those that we were not able to address during the session, this would be greatly appreciated. And I'm sure the speakers would be willing to give short answers. I think many of them can be answered in a precise way. So with that, I just share my screen and come to the conclusion. So I think we had a fantastic webinar, a fantastic mixture of Dutch with a little bit Agostinho and a little bit of myself. So azole resistant aspergillosis specifically is definitely, a hot topic, an emerging threat, not only in the Netherlands, of course, where all of it started, but really around the world and in many other countries now as well. And I think we had 3 exciting speakers. If you, for some reason, missed some part of the webinar, I can also ensure you that there will be an on-demand option. So this specific talk or whatever that you may have missed, you will be able to watch later. And so may people who were not able to join our webinar. And with that, I want to thank you for joining our webinar. I just go to do the full presentation, although it doesn't really matter because my last 2 slides are not so exciting here. And hand over to my co-chair, Paul Verweij, to conclude the session.
Yeah, so also from my side, I thought it was really interesting presentations from the bench to the bedside, I would say. So many thanks to the speakers. Also thanks to the ECMM for organizing this and to the sponsors. And also a special thank you for all the attendees who have joined us today and also participate in the discussions. So thanks very much.
Thank you.
Thanks.